very much. So I'm really delighted to be here, and it's great to see a lot of familiar faces and friends. And so I'm going to start out by setting the background for ALLHAT Relevance then, uh, 20 years ago, and to remind you that we actually uh, started planning the study 30 years ago in 1992. And we have actually, when we published the initial major results of the three drugs in 2002, we had already previously published the doxazosin results, and I'll briefly review those. And we now have over 100 manuscripts, and I know that others have published a lot of the ALLHAT data as well. So there's a tremendous amount out there. But I'm going to start back with the simplicity of where we were and what happened initially. So when ALLHAT was being designed in the early 1990s, most hypertension outcome trials had only used thiazide-type diuretic-based therapy. And in fact, one of the most impressive, the SHEP study, Systolic Hypertension in the Elderly Program, studying chlorthalidone as the diuretic, thiazide-like diuretic, showed a very nice reduction in stroke and cardiovascular events. That was sponsored by the National Heart, Lung, and Blood Institute in the U.S., who also sponsored the ALLHAT study, and several others that we'll mention this morning or this evening. And so trials with beta blockers had been done, but were very limited in number and quality, and none were conducted in the United States. But the United Kingdom Medical Research Council trial in older adults, a very good study, had just been reported in 1992, and it had shown a benefit for diuretic again, but not for a beta blocker in that study. So the beta blocker studies were mixed, and that one in particular, the beta blocker in older patients, was no better than placebo. And there were no hypertension outcome trials with regimens initiated with other classes, such as calcium blockers or ACE inhibitors. And in fact, the ARBs did not even come on the market until several years later. And so the first of the studies of other drugs was actually the CISJUR study reported in 1997. So that was 5 years after we designed ALLHAT and 3 years after we started ALLHAT. So this just gives a kind of a summary of from one network meta-analysis and showing the effect of thiazide-type diuretics. And it says low dose, although this was really the equivalent of at least 50 milligrams of hydrochlorothiazide or 25 of chlorthalidone, because that's what had happened by this point when this meta-analysis was done for the most part. And you can see that all major outcomes were reduced: 20% reduction in coronary disease, 50% reduction in heart failure, 30% reduction in stroke, and even mortality and cardiovascular disease. And so the diuretic clearly was shown to be effective, and certainly when we designed the study, it was the only drug that had consistently been shown to be effective. And despite that, what had happened was that diuretic use went from 50 to 60% in the early 80s down to less than 30% by 1992 when we designed the study. And in fact, the newer classes of calcium blockers and ACE inhibitors had actually now exceeded diuretics as the therapy in hypertension. And then, as you can see, the ARBs didn't come on until later, although they took off and were very popular. And again, the first trial of something besides a diuretic or beta blocker was not published until 1997. And so ALLHAT was developed to try and answer the question of whether these newer classes were better than the diuretics. And we didn't know and didn't know what to expect when we designed the study. We had no biases on that. But the question was, does treatment with newer agents, calcium blocker, ACE inhibitor, or alpha blocker, and we chose alpha blockers not because it was used as frequently, but because it had beneficial effects on both glucose and lipids. And would they reduce the composite endpoint of fatal coronary heart disease or non-fatal MI, so a CHD endpoint, compared with standard diuretic therapy? And that outcome was selected because that was the reason that many doctors were choosing these other drugs over the diuretic, is that they assumed that they would be better at preventing coronary disease. So ALLHAT was a randomized, double-blind, multi-center clinical trial conducted between 1994 and 2002. The population, as already mentioned, was over 42,000 high-risk hypertensive patients over 55 years of age. And so here's the general algorithm. The majority were previously on antihypertensive drugs, and then they were randomized to either chlorthalidone, amlodipine, lisinopril, or doxazosin. And you can see the numbers there, higher number for chlorthalidone, since each of these were being compared with the chlorthalidone. And you can see the doses. Target dose could up to 25 of chlorthalidone, 10 of amlodipine, 40 of lisinopril, or 8 of doxazosin. And then other drugs from other classes could be added and were provided by ALLHAT, such as atenolol, clonidine, reserpine, or hydralazine. Hydralazine often used as a third step to try and get blood pressures below 140/90. And this was the first major trial that actually had that as a goal, as part of the therapy. And we achieved about 70% of patients were below 140/90. So after a 3-year average follow-up, the alpha blocker arm was stopped early because of a substantial difference in outcomes. Primarily this 20% higher rate of cardiovascular disease, but almost twice as much heart failure and 26% more stroke in the alpha blocker arm. That probably would not be worse than placebo, but it clearly was not nearly as good as the other drugs at that point. And then a few years later, then we continued the study till the end, and then the amlodipine and lisinopril results were looked at compared with chlorthalidone. And with all three of these classes of drugs, none of the outcomes were superior for the newer drug compared with chlorthalidone. For the amlodipine, it actually did pretty well. Coronary events were similar, the primary endpoint, all-cause mortality and stroke, but heart failure was almost 40% higher with the amlodipine. And of course, now we have a lot of data knowing that calcium blockers are not as effective at preventing heart failure and hypertension. And then for the lisinopril group, again, no outcomes were better with the lisinopril than with the chlorthalidone, but stroke, combined cardiovascular disease, and heart failure were better with the chlorthalidone. And so this heart failure was a consistent finding with all three of the classes where the diuretic was better. Now, with the I'm not going to show you all the subgroups, but as you may be aware, there were no subgroup differences, no heterogeneity based on having diabetes or prior cardiovascular disease, age, men or women, CKD. All the subgroups showed similar effects of what I've already just shown you, except for lisinopril chlorthalidone comparison in Black patients. And so here what we saw with the lisinopril chlorthalidone comparison was that Black patients actually did a lot worse. And that has now been seen in other studies and is reflected in all the newer guidelines, which my colleagues may mention. For the non-Black patients, the differences were less so, and only heart failure was significantly worse with lisinopril. And I don't have time to go into it, but it really was predominantly preserved EF heart failure that the diuretic was superior to the ACE inhibitor, and they were actually similar for preventing low EF heart failure. So this shows, of those who were withdrawn from the drugs, what were the causes of that? And about 3 to 5% of all participants over 5 years were withdrawn because of adverse effects. And what I wanted to highlight is that the diuretic actually had the least percent of patients that were withdrawn because of adverse effects. A little bit more for biochemical effects, but still very low rates of being withdrawn for things like hyponatremia or hypokalemia. And so this then was reflected in the year after the ALLHAT results were published. The U.S. Joint National Committee report number 7 in 2003 then recommended, and this is the algorithm, and when it comes to patients without a compelling indication for one of the other agents, then for both stage 1 and stage 2, thiazide-type diuretics were preferred as initial therapy, either alone initially or in combination. And we recommended in the patients with stage 2 hypertension to start with 2 drugs, as has already been alluded to, and that one of those drugs should usually be a thiazide-type diuretic. And so the antihypertensive trial in ALLHAT has implications. At that time, thiazide-type diuretics were recommended to be the drug of choice for initial therapy of hypertension in the U.S., both for the JNC7 and also for the U.S. VA Department of Defense guidelines, unless there was a compelling indication for another class, which certainly could be the case. For the patient who couldn't take a diuretic, which we said should be an unusual circumstance, calcium blockers, ACE inhibitors, or then later ARBs could be considered. And in Black hypertensive patients whose major risk is for a cardiovascular event, thiazide-type diuretics or calcium blockers in those who couldn't take a thiazide diuretic were recommended over RAS blockers, and that has been reflected in subsequent guidelines as well. And then most hypertensive patients we thought could require more than one drug. Diuretics should generally be part of the antihypertensive regimen, and almost all combination regimens are more effective when a diuretic is included as well. So I'm going to stop with that brief review, and I thank